Okay, tumor spread. We're in the home stretch. There we go. Okay, so metastasis, the movement of the tumor. If it's metastasizing, it's a benign or malignant. It's malignant. It's one of the traits of malignant. It's moving or spreading outside of its isolated area. If it's a malignant cancer, but it's still isolated to the original area, what's it called? Cancer in situ, right? So some of the phrases you want to make sure you're familiar with. So when you look at the movement spread of cancer from primary site to origin to distant sites, there's actually a sequence to it. So the first thing is that it has direct extension. The little cancer cells start reaching itself out and pulling. Right now, it's kind of actually stuck in its area. They're trying to pull free. Soon what's going to do is it's going to release enzymes that break it free, and we'll talk about that. And then it penetrates into the lymphatics or the blood vessels, and then it can go where? Anywhere at once, exactly. It just transports all over the place. So ideally what would happen is you'd clear it from your system somehow, but it's a human cell, so your immune system may let it slide on right by. And it can plant anywhere at once. Right? And they call that seeding, by the way, when it's moving into new areas. So it moves through the lymph or the blood, and then it's transported to a secondary site, and then it starts growing in that secondary site. Like I said, that's called seeding. So where it goes from the primary tumor and then starts growing off other places. I think I have this in the slide, but if I don't, there's something called tropism, organ tropism. It's on the next slide. So, like if I have a cell that starts here at breast tissue, there's something about the cells in the breast that they like their environment. It's typically a fatty type environment. When they get into the system, they would move to other places that are fatty-like the brain. They have a tendency to metastasize to specific organs, and that's called organ tropism. They have certain preferences for where they go. All right, so 3 forms of tumor spread. The first one's called local. And the local spread means it just directly invades another type of tissue. So we get this tumor starting wherever it's at, and then it starts growing and pushing into the surrounding tissue. That's local. It could be a tumor that's actually increasing its size and pinching off. Would that cause pinching off blood vessels? Would that cause any damage? It could. What else could it pinch off that would cause problems? Nerves would be another big one. And a lot of times that will cause things like pain. So local invasion of the contiguous tissue. And then once it gets into the lymphatics and the blood, then it can move downstream. When it's moving downstream, it wants to invade. So once it gets into the lymphatics or the blood, it moves downstream, down slow. It's floating along. Now it's going to start grabbing a hold. When it grabs a hold of this side of the blood vessel, it's going to try and invade in. So what it's going to do is it's going to release enzymes. I kind of mentioned this before. It releases enzymes that invades into the wall. It actually grows this little thing. It's like a podocyte, or a foot cell. So it's a pseudopodia, technically. It's a false foot. It grows its foot and kind of wedges its way into the doorway and pulls its way in. As it's doing that, it's pulling itself in. It releases these lytic enzymes. Whoops, lysis or lytic. Digesting, breaking down. So it's breaking down all of these cells in their neighborhood, destroying them to move into that tissue. And then the same thing when it breaks free initially, it does the same thing. It releases these lytic enzymes to start spreading its way out. So, invasation and extravasation, 2 terms. Intravasation means it moves through the membrane and into the blood vessel. Extravasation means it moves back out. So, at the original site, you have intravasation moving in, going downstream, and then you have the extravas moving out of the vessel. In the site. And that's the local spread. And then there's that word. So, organ tropism. It means that certain cells, certain cancer cells, depending on where they originated at, they have preferences where they grow. Some cells don't care, and they just go all over and they start causing cancers everywhere. But, like I said, a good example is breast tissue. Because when somebody has breast cancer, even after, let's say they've had mastectomy, they had the cells removed, the entire breast removed, where's the second place they have to worry about it coming back? In the brain. A lot of times it has a tendency to go to the brain. There's another area that likes to go to the lungs. So usually about 5 years down the road, they start worrying about that original breast tissue, the breast mass, if it was large enough, it metastasizing into the brain. So preferential growth. Right. So the theory of invasion, first, the tumor cell attachment, it grabs a hold of its area. This fibronectin stuff is just a sugar protein that helps it grab a hold. It's like glue. And I'm not going to pop up fibronectin later anyway. But it's just tumor attachment. Before it had to get rid of its attachment structures, now it has to build new ones by distilling in. Once it's at its site, it degrades the environment, the lytic enzymes again. It used lysis to get free the first time and move into the tissue. It used lysis to get into the new tissue. These cancer cells, they're tricky. They're mutating constantly, and they're trying to find new ways of invading. It's like a bacteria. The bacteria keeps replicating. You can kill off a bunch of it, but then these mutated ones get stronger and stronger. Cells, cancer cells are the same way. They keep mutating. They keep replicating a lot of cells, so they keep changing. And then the movement, invatopodia, they're actually pseudopodia. They're not real foots. Feet. They're not real foots, right. So invatopodia, just say it says invasion foot. Pseudopodia means it's a false foot. It's not a real foot. It just works its way in. I know, because they needed to explain that that's not a real foot. But it just has a special name. Okay. And then this isn't an oncology class, so we're going to make things kind of general. When we talk about the stages of metastasis, we have 4 typical stages we'll refer to. The first one means it's confined to the site of the origin. What's that called? There's a name for that. In situ, yeah. So if it's still confined to the site of origin, it's in situ. So here's normal healthy tissue up here. And this one's stage 1 in situ. It's still in the same tissue. It hasn't moved out. Stage number 2, it's locally invasive. It's moved beyond its origin tissue, and it's actually invading the surrounding tissue. So let's say it moves out and invades the connective tissue. Maybe it invades the muscle out here. Here it was isolated to the endothelium, if that was endothelium. It moves out. So if this is the GI tract, here's the epithelium, or the mucosa and the submucosa. It's isolated. But now when it starts moving out into the muscle tissue, now it's locally invasive. Stage 3 is when it gets into the lymphatics. So it's spread to regional structures. It gets into the lymph nodes and starts moving to the local lymph. It can't go everywhere yet because it's still isolated to the lymphatics. But it's spread to another area. So let's say that maybe this spread to, let's say, lymph in the chest. You have lymph nodes in your chest and it moves upwards into your chest. Let's see, if this were a cancer that were testicular cancer, maybe it moves over to the groin. So it moved into lymphatics in the groin. That would be a stage 3. And then stage 4, spread to distant sites. So at this point, it's in the blood, it goes anywhere at once. So it may be prostate cancer that spread to the brain or the lungs. Like I said before, breast, an example of stage 4 was where would it have gone to? Yeah, up to the brain. If it were breast cancer or locally invasive, it may go over the armpit, so causing inflammation in the lymph nodes everywhere. Or locally, regionally. Number 3. And then if you get on to practice and they go into better details, they'll call it A, B, and all that rating. And that was stages. Grading, stages is location where things are at. Grading is how much change actually happened to the original cells. So when you're looking at grading, grading goes on this continuous scale. So stage number 1, and I'm not going to test you on it, what is 3A, 3B, or 3. Stage number 1, they look like a normal cell, it's the key. These look like the cells of origin. So if this were, let's say, a uterine tumor, okay, if it still looks like the original cells, then it's a grade 1. When you start looking at those cells and they start changing and getting this anaplastic form, which is a weird form, this is going to 2. If most of them are really deformed, it's stage 3. If they're extremely different, it's stage 4. If they look nothing like the original cells, we call it stage 5. And like I said, this varies so much depending on the type of cancer and everything. The key you want to remember is that stage 1 was more like a what? A normal cell. Stage 5 was absolutely nothing like the normal cells. It's completely changed. So if I asked you a question like that, I might say, which is most different from a normal cell? Stage 1, 2, 3, or 5? be 5. Or which stage looks most like a normal cell? Would it be 2, 3, 4, or 5? It would be 2. It's most like a normal cell. It's not exactly a normal cell. So stages is talking about location, how it's moved. Grading is talking about the differences changed since it started. And the last bit here, epidemiology, manifestations, and some treatments. And here are the main objectives you want to kind of focus on. So the first thing, manifestations. What are the clinical symptoms of cancers? And one's pain. And pain, pain is usually because of compression or mechanical stress on structures. So if the tumor's growing and it's squeezing on a neuron, it may send faulty signals to the neuron, causing this pain signal. It may also cut off the neuron, causing numbness or lack of sensation. Typically in the early stages of cancer, there's not a lot of pain because there's not a lot of growth. And then later, the whole pain issue. Pain is relative. It's actually very subjective. You might poke somebody in the finger with a pen and they do nothing. You might poke another person and they start screaming bloody murder. So there's a lot of variance. When people are afraid or distressed or anxious, the pain seems to go up. So there's a lot of influence. If somebody has cancer and they know they have cancer, they're going to be more aware of the pains in different places. Right, so pain. And then some of the mechanisms I already have up here. Pressure, so squeezing on blood vessels, squeezing on neurons. When you squeeze the blood vessel and you decrease the blood flow to the tip of the neuron, then the neuron starts misfiring. So it could be either. Stretching, so the tumor's growing and it's pulling. It's just like me pulling on your skin. You start feeling that pain response. And then the inflammatory response, so inflammation. Okay, so cancer-related fatigue. Fatigue, by the way, is the most frequently reported problem. So frequently reported symptom. And I've just been feeling so tired lately. Maybe I've been working myself too hard at work. Fatigue's another subjective one. Can people fake fatigue? Yeah. I was going to crack some joke about marriage. So, I'm just too tired tonight. Right? And we're going to keep it at that. So, yeah, you can fake that. And then, it can be affective, cognitive, and physical fatigue. So, actual physical fatigue, they want to do things, but they're so physically exhausted, they feel weak, and they just feel tired, breathless all the time. They just feel like they can't do it. Think about this cancer. This cancer is stealing lots of good resources, and it's stealing it for themselves, depriving the rest of the body of those resources. So oxygen and nutrients. Cognitive, poor concentration, their actual mental functioning. So it's not mood. Mood would be affective. So if they just seem really irritable, really cranky, that's an affective disorder. Affective result. Depressed, that would be an affective fatigue. Just emotionally drained. Cognitively, they can't concentrate on things. And then physically, where they can't actually move, or they feel too tired to move. So treatments are affecting, basically when they have cancer, it depends on what it is in the fatigue they try and treat. So obviously, if it's an affective situation, they may give them something like an SSRI to help boost up the mood. For cognitive, they may increase mental gains and activities. And then for physical, focusing on diet primarily. Right. Next one, syndrome. Syndrome's a group of symptoms. So cachexia is a group. And cachexia is a combination of pain, loss of appetite, fatigue. It's a combination of things. And a lot of times the cachexia is related to the chemotherapeutic agent. So they lose their appetite, which causes malnutrition. And cachexia is one of the most severe forms of malnutrition. You can see that they're wasting away. And it's not because they're trying to look slim like anorexia, like where people have a psychological issue. This is an anorexia because they can't eat. Why would they not be able to eat? You think of this. What's being affected? The hypothalamus might be affected. Think about the GI tract. If you're on a chemotherapeutic agent, what does it target? It doesn't just target cancer cells. It targets any cells that are doing what? Rapidly reproducing. Skin cells, stomach lining, small intestine, large intestine lining, all of the linings, they're all epithelial cells that are rapidly reproducing. So think about the skin. What symptom would that cause if it's stopping rapidly reproducing cells in the skin? And I know you know the symptom, causing them to start losing hair. Yeah, they have dry, pale skin. They're losing hair. The skin gets dry and flakes off real easy. Peel it off the sheets, just flakes off a lot more easily. Think of the GI tract the same way. Your GI tract turns over about every 7 to 10 days. You've got a brand new inner lining of the GI tract. If they can't reproduce that, it just keeps sloughing off. It would be like having, I can only imagine it being like having ulcers lining all the way along the GI tract. Would you want to eat anything? No. So it's not because they don't want to eat, it's that they feel like they physically can't eat because it makes them so upset on the inside. Okay. Malnutrition is one of them. And then pain symptoms. And when people die, about 80% of people at death with cancer have cachexia. So you can see some of the symptoms. A lot of them related to GI tract. So anorexia, early satiety, weight loss. What about anemia? How would that be affected based on something like chemotherapy? Decreased reproduction of blood cells. Remember, 5 million a second, that's a lot of red blood cells. If you're turning it down, then you're not making enough red blood cells, and what's that called? Right. And then, oops, I put that slide in, but there it is, anemia. So you have to think of it as in the red blood cells are rapidly reproducing. If you have deprivation of oxygen to the tissue, if you have lack of nutrients in the system, if you have lack of certain vitamins, or if you're taking a chemotherapeutic agent that turns down red blood cell production, you get anemia. We'll talk about anemia with the cardiovascular system again, but anemia is typically not a disease. Anemia is typically a symptom. So it's usually a symptom of some other disease. So it could be malnutrition with the iron reabsorption. They can't get iron in efficiently because their GI tract's bad. So they have iron deficiency. Chemotherapeutic agents can actually turn it down. So does anybody remember the name of the chemical that your body makes to turn up red blood cell production? Erythropoietin. Keep that in your head. So it's erythropoietin. When they give somebody a chemotherapeutic agent, guess what artificial hormone they also give them with that chemotherapeutic agent? Erythropoietin. So synthetic erythropoietin, because the chemotherapeutic slows it down, but the fake erythropoietin speeds it back up. Lance Armstrong. Right? I still didn't watch the video, but I've heard so many conflicting opinions on that Lance Armstrong video. But that's one form of blood doping, is taking synthetic erythropoietin. It increases your red blood cell production, increases your oxygen carrying capability, and makes you able to exercise longer, or maintain exercise longer. All right, next one is, this goes right along with the anemia, leukopenia, and thrombocytopenia. When you see these penias, it's talking about a decrease. What would leukopenia be? Decreased white blood cells, and thrombocytopenia would be decreased platelets, which are thrombocytes. And if you remember, the easy way to keep this in mind is that all three of those are referred to as the blood cells, right? So if you're affecting rapidly reproducing areas like the bone marrow, all three of these get turned down. What's going to happen to your immune system? It's going to get turned down, right? So you're going to be more susceptible to other things. So cancer is going to leave you susceptible to get more cold, more flu, all those things. How about your ability to clot blood? It goes down too. So if they get cuts or injuries, if they actually get that for real ulcer, what's going to happen? It could actually get excessive internal bleeding, right? So they can't clot properly. And then chemotherapeutic agents they take for the cancer, you want to keep in mind that they target things like bone marrow. It's toxic to the bone marrow, which increases the risk for infections. This next one is an interesting one. Paraneoplastic syndrome. When you think paranormal means outside the normal. When you hear about para anything, it's referring to outside of this category. So a neoplastic syndrome is a cancer syndrome. But a paraneoplastic means it's outside the actual cancer. And this is where it's tricky. It's not the cancer causing the problem. It's something else that's a result because of the cancer over here. like I said, it's kind of a tricky thing. It's not the cancer itself. It's the result of something else in the body that's causing a problem. Like, for instance, I'm trying to think of good, well, anemia. Anemia could be a symptom, which we technically a paraneoplastic syndrome. A part of the paraneoplastic syndrome. Okay. And then, like I have up here, they're not explained by the cancer directly. There's something else that's going on. And so this is kind of interesting. They looked at contracture of the fingers. This is a symptom where these people, they actually have their fingers contracted like this. They can't open it up. Most of these people that had this symptom, when they went into the doctor, they actually had different forms of cancer, typically breast or ovarian cancer. But it's not the cancer that caused that. It's the result of something else being deprived of their body. So they saw it as a warning sign. I thought this was really interesting. So, when you see these contractures or pre-arthritic conditions, they found that typically about 5 months before being diagnosed with ovarian, breast, or prostate cancers, these things would happen. So they start getting these really weird symptoms. It wasn't the cancer itself, it was some other thing that just happened to be correlated with the cancer. Paraneoplastic. And then how they treat it. So, of course, we all know the first type, chemotherapy. So, chemotherapeutics, radiation. So they can zap the tumors, they can hit it with chemicals, they can cut it out, which would be what? Fancy word? Cutting it out? Surgery. Incising and taking it out. So there are a lot of different methods, and the first one is chemotherapy. And chemotherapeutic drugs, when they give them the drug, it usually goes into the specific tumor cells, and it slows down its replication. Why can't they just kill everything? Why can't they give a drug that goes through the cancer that wipes out that specific cancer? Because these were human cells. If you give a drug that targets something inside of a human cell, is it going to stop at the cancer cell? No, it's going to go all over the place. So typically they give drugs that will do one of two things. It either goes inside the cancer cell and stops the replication process. It tries to stop from replicating, but unfortunately it goes to epithelial cells and red blood cells and white blood cell producers, and it stops them from reproducing too. The other thing they can do is if they know that specific thing on the surface, you remember what that was called? A tumor marker. If they know the specific marker, they can actually target it for the marker. I'll talk a little bit more about that later. But so they can either target something that's already existing inside the cell, or they can look for a specific tumor marker and target that marker. In fact, they can turn your immune system into an army against that tumor marker if they know what the marker is. All right. So chemotherapeutics, they slow down growth and replication, but not just of tumor cells, but also normal cells. The whole goal is to cure the cancer. What they're trying to do is they slow it down enough so they can get the person into surgery or radiation and zap all the surrounding cells. So they can kill the tumor and or extract the tumor. So just basically postponing growth so they can do that. The other purpose is to try and control the cancer. Some people, there's no cure for them. The cancer's so bad that when they give them chemotherapy, so they're trying to slow the progression. And the third thing, to ease the symptoms. If you have a rapidly growing tumor and symptoms keep getting worse, then if you give them a chemotherapeutic agent, that can slow that growth down. There are a couple different types. Like I already said, you can have inside, you can have outside. You can also have single agent. Single agent chemotherapeutics focus on one thing about the cancer cell, just one characteristic. So if I had a prostate-specific marker and it was targeted at that prostate-specific marker, it would just go to the prostate cells. That would be ideal. The problem is what caused the cancer in the first place. It did what? So what? It didn't follow the rules and it mutated. So it started mutating. If I target one simple thing about this, and before that chemotherapeutic agent gets there, what could it have done? Mutated. So now I'm targeting that original cell, but now it's mutated. And so all it is eliminated the first cell. So single agent chemotherapeutics, they target one thing. That's it. They're kind of high risk because if you kill that cell off but it already mutated, then that new cancer is going to spread like crazy. So usually they use a combination chemotherapeutic where they'll target several types. Remember when we talked about colon cancer, there are 4 stages? We can identify those specific stages. If we know the stages of development of a typical cancer cell, we'll target the first, the second, and the third stage and give them all 3 chemotherapeutics, whether they need it or not. just so that we get rid of the first one and then we prevent the second or the third, or just in case it mutated with someone along there, we stop them. So that's what a combination of chemotherapy is. So mixing different things to try and target different types of cancers, usually in a predictable fashion. Okay, principal dose of intensity is the dose that they find kills enough cancer cells without killing that many human cells. So if we give you a specific dose that most people, like your age, your height, your type of cancer, et cetera, we find that this is an effective dose. That's what they shoot for. The therapeutic index is how much can we give you before we actually kill you. So they look at the average person, your age, height, weight, sex, et cetera, with your type of cancer. For us to kill that whole person and kill all the cancer cells is how much we give them. You don't want to give them that much. So the therapeutic index is proportional. And typically, what to do is they'll shoot for a 25 to 50% therapeutic index, which means that in about 25% of patients, it can be potentially lethal. And then neoadjuvant. So an adjuvant treatment is something given with the primary treatment. A neoadjuvant is something given before the primary treatment. So typically neoadjuvant they'll give, if it's neoadjuvant chemotherapy, they give it to them before they go into surgery. It's to try and stop the rapidly reproducing cell. They're hoping to keep it isolated so they can get in there and pull it right out. So adjuvant therapy is something given in addition to the primary therapy, and neoadjuvant something given right before the surgery. Radiation. So radiation can cause cancer by mutating cells, but it can also kill the cancer by destroying the DNA. I used to go up to Fermilab every summer, and they had this, it was a really cool building where they were focusing on cancer treatments, and they were especially focusing on thyroid treatments, thyroid cancers. And they had this huge concrete room with really thick walls, but they had this real tiny, like almost microscopic pinpoint hole going through one of these like 2-foot thick walls. And what they would have is they would have a person standing on a little machine on the other side of that wall, and they'd expose radiation on one side of the concrete. Just a fine line of particles could squeeze through that hole, and they would actually line the person up so that that fine line of particles would go straight into the thyroid and destroy the cancer. So that was kind of good because they could isolate it to a really small region. The problem is that it would also cause some inflammation around there. So would you want a lot of inflammation at your thyroid? Why? It's on your throat, right? So there are some setbacks to it. Too much of that inflammation can actually cause other problems. But the whole idea is to hit that cancer cell with enough radiation to destroy it without killing all the other surrounding cells. So the benefit is they can be precise with where they use it. The bad thing is the inflammation can cause side effects. And then there's some other things like surgery. And yeah, this is my don't chew tobacco public service announcement. But this guy was a tobacco chewer, and they did a debulking surgery. So he had tumors growing all through here. They actually removed this entire part of his jaw. There you can see it, teeth and all. Yep, so that was surgery. So typically they'll do a biopsy, they'll extract some tissue, they'll see exactly what's going on, and then remove that area. And they usually remove extra tissue because they're afraid that if these cancer cells spread into the area, that if they miss them, it's just going to come back anyway. So they usually take out more than they need to. So, yep, they had cancer all through here, and they just removed the whole area, including the teeth. Those look like healthy teeth. Somebody could use those. There's somebody in Kentucky right now going, dang it! If you're from Kentucky, I apologize. It's a joke my dad and I have going on. He wants to retire in Kentucky, and I always rip on him. And I'm sure you've heard me tell that story before. But anyway, so biopsying with the surgery, they can take a sample out and make it look exactly what it is. They can see some of these breast cancer cells. They go to the brain, they do a brain biopsy, and they look at it. It looks like a piece of brain or breast tissue. They know what happened. It didn't start in the brain as breast tissue. It metastasized. Yep. So by doing the biopsy, they can actually see where the cancer is coming from. They can do debulking, where they take a lot of large section out to make sure that they effectively remove it. Palliative surgery typically happens with people that they can't cure the cancer. So what they do is they remove enough of the cancer so that it makes them more comfortable. So if it's growing around nerves or around certain blood vessels or growing around their lungs where they're having problems breathing, they'll go in and remove it. Even though they can't cure the cancer, they're just reducing their suffering. So. And then hormone therapy. Hormone therapy, they can actually, if it's estrogen, increases the rate of cancers. So if they give you too much estrogen, they can actually reduce it by blocking some of the estrogen receptors. And the last one, immunotherapy. This is where we train your immune system to attack the cancer. And this is kind of like the future. If we can find specific markers on the surface of the cancers, then we can train your white blood cells to go after them and destroy them. Because the white blood cells have access to almost everywhere in the body. If we can teach them what the cancer cell looks like, they can target it, they can go after it, and they can actually isolate it and kill it. But this is kind of like with the genetics, where we can make medications later for you based on your genetics that are specifically working for you. The same thing. We'd have to pull out the cancer cell. We'd have to isolate the characteristics on the cancer cell. We'd have to expose it to white blood cells, make all these immune factors, re-inject them into you specifically for you. So it's kind of a long and drawn-out process and very expensive right now. So it's kind of the future. If we can make your immune system kill your cancer cells, it's ideal. Because your immune system already knows how to kill cancers. It's just not the most efficient yet. And there are certain markers that make that cancer cell say, hey, I'm human, don't kill me, and then it just keeps replicating. So it can be very destructive. Okay. And then other forms, so things like interferon administration. Interferon, we haven't talked about the immune system yet, but interferon blocks the passage of viruses from one cell to the other, so we can slow down the progression. Interferon also slows the replication rate of some cancers. Antigens, we're going to talk about a lot of this with the immune system. So antigens are also those little tumor markers. They're little characteristics that are on the tumor cells that say, hey, I'm not a normal human cell. And you can target it and kill them. Effector lymphokines, these are chemicals that stimulate your immune system. And then monoclonal antibodies. This is an interesting process. The way they used to do it is they would take something that would affect you, like anything, any kind of virus that affects you, but not a horse, and they'd inject it into a horse. Or they'd take this little virus and inject it into a mouse, and they'd kill the mouse. Because the mouse's immune system goes, hey, this isn't going on here. And it would actually make immune antibodies, little tiny protective factors specifically for that virus. It couldn't hurt the mouse, but the mouse is cranking out these immune factors. So we'd take the mouse's blood out, we'd filter it out, we'd take those antibodies and then inject it into a human, and those antibodies would go in and kill that same thing. It's kind of a cool process, and we use this process for lots of things now. But again, this is kind of like the future, where things are going with cancer treatments. If we can basically bump up your immune system to do the job for us, then that's awesome. Right? And then side effects of cancer treatment. I've already listed some of these, like the GI tract. What's the problem? Cancer treatment, chemotherapy is doing what to the GI tract? It's decreasing its ability to heal and replicate. Yeah, these are rapidly replicating cells when you look at the mouse. So if it's not replicating, it's thinner and thinner and thinner, which means you're more susceptible to things like ulcers, invasion, and infection. So the side effects of cancer treatment is, remember, any of the places that are rapidly reproducing, you slow down. GI tract, it can't reproduce itself as fast as it's thinner, it gets more delicate, more sensitive. What about the bone marrow? What do you worry about in there? Blood cells. Yep. Red blood cells, white blood cells, platelets. These are rapidly replicating cells. How about hair and skin? I'm hoping you're noticing a theme. So, the skin, rapidly replicating. We slough off our skin constantly. The skin makes the hair. If the skin is not replicating efficiently, it's not getting appropriate nutrients, is it going to take time to make good, strong nails and hair? Nope. So the hair gets thinner, and then eventually the hair starts coming out. That's a reproductive. Oh, no, reproductive tract. And then a reproductive tract, of course, things like the lining of the uterus constantly reproducing, getting thicker, 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 and then shedding off. Same thing with sperm cells, constantly reproducing. 24 hours a day we're making sperm cells. So if somebody's on a chemotherapeutic agent, what's going to happen to their sperm count? It's going to drop. Yeah, they can't keep reproducing those cells. It's turning down anything that's rapidly replicating. So reproductive tract in women, you want to think of things like the uterine lining, and in men you want to think of like the testes, constantly making sperm. So all of these, the chemotherapeutic agents, are all affecting things that rapidly reproduce. So if somebody gets a cut, what's going to happen to their rate of healing? It slows down. It's just one of those side effects. And then the last couple slides, cancer and treatment, or cancer in children. So the incidence, just like adults, second leading cause of death in children. We talked about heart disease being the leading cause of death in adults, cancer being second, same with children. So second leading cause of death. And then 9,500 children diagnosed annually. So childhood cancers. Most of them actually stem from the mesodermal layer. So as you're growing and developing, that's the connective tissue, that's the bone, that's the muscle layer. It's the middle layer. The ectoderm is the skin and nervous system. The endoderm is anything that's like hollow organs, GI tract, lungs, urinary tract. And the mesoderm is anything in between. And it's usually that mesoderm that has the flaws. So it's typically in like connective tissue or muscle cancers in children. The most common ones, leukemias. So leukemia, sarcomas, embryonic tumors. And leukemias, what's it affecting? White blood cells. And then sarcomas, the connective tissue again. And embryonic tumors are basically just the embryonic cells. They start causing problems. Like in this situation, you can see the tumor growing on the chin. So it doesn't differentiate into the appropriate cells and just keep replicating. It acts like a stem cell, which is what a cancer cell does, and just keep replicating. Right? And then since leukemia is the most common form of childhood cancer, we'll spend some time on that one. Okay. So most common malignancy in children. Do you ever have a benign leukemia? Nope. I think I've said that like 5 times now. Just saying. Might want to know that one. What's the other one that I said with leukemia? Lymphoma, right? And then I mentioned this with Down syndrome. Children with Down syndrome have an increased risk of leukemia. What was the other health problem they have an increased risk of? Heart disease. So leukemia and heart disease. Just out of memory, anybody remember what 97% of all Down syndrome is caused from? From trisomy 21. Yep. So when you're trying to pull apart the chromosomes, once that sticks together. And then, anybody remember the last 2%? Started with a T. Actually, it was Robertsonian, somewhat of a T. Translocation. Yep. So Robertsonian translocation. Which one had a higher rate of parents having multiple kids with? How did I get that out? Which caused the multiple chances of having Down syndrome over and over again? Was it the trisomy or the Robertson? It's the Robertson. Okay, so it's kind of a flashback to last week's information. So leukemia is the most malignant. Sarcomas are bone tumors. They're connective tissue in general, but typically it's a bone tumor. And then other common cancers, neuroblastomas, which we talked about a little bit earlier. And then Wilms tumor, you don't have to remember this. It's a nephro tumor. What would that mean? Yeah, exactly. So, nephroblastoma. And you remember what rhabdomyosarcoma was? Yep. It's connective tissue. It's a transition between bone and muscle. So it's connective tissue that's holding bone and muscle together. And then the last one, retinoblastoma. That was because of the RB gene, and it typically happens in the eye. All right. And then ecogenetics is kind of a buzzword again. It means environmental plus genetic factors. So it can be environment plus genetics. But some of the genetics are passed down from mom and dad. Some of it happens in utero. It was passed down from mom and dad. Usually you see it early in life, like retinoblastoma. And there's sometimes environment that also affects it too. Okay, and then some of the causes, chromosome abnormalities like aneuploidy, which we talked about, that would also cause Down syndrome. Amplifications and deletions, sometimes you get an accelerator gene that's stuck on. Maybe you have a loss of a break. Robertson-Only translocation, so sometimes you take a piece and switch it over, which also causes the Down syndrome. And sometimes it's just a fragile area. So there are a lot of chromosome abnormalities, and this is basically going back to the end of last week's lecture. And then with the oncogens and tumor suppressor genes, when they're healthy, they're called a proto-oncogene. That's a good gene. If you have something that affects it and shuts it off, it's now called an oncogene, which means it's a tumor enhancer. So proto-oncogens are good. Regular oncogens, bad news. And then Fanconi's is another one of those diseases. It's like Tay-Sachs. It's more prevalent in Ashkenazi Jew populations. But what happens is they overproduce certain proteins that are accelerator proteins. Oops. And then Bloom's is actually the same thing. But Bloom's causes physical deformities too, like short characteristics. I'm stuck here. There we go. And then environmental prenatal exposure, so while they're still in womb. Nutrition and diet makes a huge difference. Make sure they have the nutrients to grow properly and develop. Not eating that charred food. Mommies that are expecting should be eating lots of over-grilled meat, basically. I'm trying to keep that in mind. My wife is like not letting me eat anything that's good anymore. Not because of me, but because she can't have it. No, it's not. It's not fair at all. I'm putting on that weight too, so that's not fair to me. She gets to lose. She has like a diet plan. All at one time, she's going to lose a bunch of that weight. I'm not going to lose it that fast. And then childhood exposure to things like secondhand smoke, too many X-rays, and I think I talked about this before. Back when they first came out with X-rays, they thought, man, this is awesome, and they started zapping everybody with X-rays. There might be something wrong inside you. Zap them with an X-ray. Pregnant women, let's see how far the baby's progressed. Zap them with an X-ray. Let's do this like 8 times through the progression of the baby and see what happens. So ionizing radiation can be bad, and then of course viruses. And I think this is our last slide. So prognosis: childhood cancers have a 80% survival rate. So 5-year survival rate about 80%. And we'll talk about leukemias when we get to the actual blood cells again. So we'll go in better detail. The upside is that children are more responsive to changes, so they can handle chemotherapeutics typically better than an adult can. Because if you slow down the growth for long enough and then you take out the cancer, when you let them go, their bodies are primed to grow. So they'll start growing and repairing. So much so that even when we get into the brain, I'll talk about a story where a child had half of her brain removed, and now she's an adult and acts just like a normal adult. They tolerate treatments better, they heal a lot better. And then their psychological effects are a lot better too. As adults, we respond a lot differently than a child does. All right, 3:52. We're out 8 minutes early. So do lecture is it number 4? It's the one that says cancer afterwards. Don't leave. This says cancer afterwards. And then when we come in next week, we'll do a test over just genetics and just cancer. Everybody got that, right? When we come in, we'll do a test over just genetics and just cancer.